Hello friends. So today we'll be discussing about drugs for peptic ulcer. Okay, so you're all familiar with peptic ulcer. So basically what is peptic ulcer? It is a condition where there is a breach in the gastric or duodenal mucosa at least to the depth of muscularis mucosa. So based on that, it can either be a gastric ulcer or duodenal ulcer. Okay. Now, what is the etiology or what causes peptic ulcer? It is basically an imbalance between the protective and the aggressive factors. What are the protective factors? The protective factors against peptic ulcer or ulcer formation is your mucus production, the blood flow, bicarbonates, and prostaglandins. So these are all the protective factors that help in preventing an ulcer formation. What are the aggressive factors, or what are the factors that aggravate the formation of an ulcer? Anything that is spicy, drugs like NSAIDs, steroids, then alcohol, stress, genetics, and finally H. pylori infection. Plus, there is increased acid as well as gastrin secretion. So, all these are aggravating factors. So, when there is an imbalance between the protective and the aggravating factors, that can result in peptic ulcer. Okay. So now we'll see briefly how acid secretion is regulated. We all know that acid secretion is by the parietal cell. So this is a gastric parietal cell. Okay. So you can see here there are proton pumps, otherwise known as H plus K plus ATPase pump. Okay. So this is the final step that secretes the H plus into the lumen. Okay. So there are three main stimulants for this acid secretion. One is your acetylcholine that acts mainly on the M3 receptors and little bit of M1 receptors also. Then you have gastrin and then you have histamine. Okay. So when there is dietary peptides coming in the lumen, that will stimulate the G cells to produce gastrin. Gastrin will go and act on the CCK receptor and will stimulate the H plus K plus proton pumps, as well as gastrin will stimulate the enterochromaffin like cells to secrete histamine. Histamine will have a direct action by acting on the H2 receptors. It stimulates the acid secretion. Similarly, when vagus nerve is stimulated, it causes release of acetylcholine that has got a direct action on the parietal cell. Plus, it stimulates the release of gastrin as well as it stimulates the release of histamine from the enterochromaffin like cells. And finally, you have increased acid production. So, if you're familiar with this, now we'll know which are the drugs that we use to decrease the acid production. So, now we come to the classification of drugs for peptic ulcer, which is very important. Okay, so we have the major group is drugs which reduce the gastric acid production. So we have the H plus K plus inhibitors or the proton pump inhibitors. Then you have the H2 receptor blockers. Then we have anticholinergic agents and prostaglandin analogs. So these are the drugs which reduce the gastric acid secretion. Then we have drugs which neutralizes the gastric acid, which are known as antacids. Then we have drugs which form a protective coating over the ulcer, which are known as mucosal protective agents or ulcer protective agents. And then we have anti-H. pylori drugs, because H. pylori is a major contributory factor for development of peptic ulcer. So we have anti-H. pylori drugs. So now we'll come to this major group that reduces the gastric acid secretion. So in this picture you can see this is the parietal cell. This is the final step, that is H plus K plus ATPase pump or the proton pump, which is inhibited by proton pump inhibitors. You have the gastrin, which is one major stimulant for this release of H plus. Then we have histamine, and histamine is blocked by H2 receptor antagonists. We have prostaglandins analogs, which again will inhibit the release of acid secretion. Then we have anticholinergics, which inhibits the release of acid secretion. Okay. So first we'll come to the most important group, or the final step in acid secretion is by the proton pump. So proton pump inhibitors are having the highest efficacy in inhibiting the acid secretion. So what are the examples of proton pump inhibitors? You have omeprazole, pantoprazole, rabeprazole, everything ending with prazole. Okay. Elaprazole, tenetoprazole are the newer agents that we use for peptic ulcer. And the peculiarity is all these agents are prodrugs. What are prodrugs? They require activation inside the body to their active compound. So for these agents, they require activation in the acidic environment. They get activated within the canaliculi of the parietal cells. Okay. These are irreversible inhibitors of proton pump or H plus K plus ATPase enzyme. So what do they do? So this drugs, this omeprazole or rabeprazole, pantoprazole and all, they get destroyed in gastric acid. So in order to protect them from gastric acid, what we do? We do it as a entry coated tablet. And this tablet, once we ingest this or once we take omeprazole in the intestinal, when it reaches the intestine, so it is protected from the gastric acid because it is entry coated, reaches the intestine where it gets dissolved and the drug gets absorbed into the circulation. And once it, after absorbed into the systemic circulation, it gets diffused into the canaliculi of the, so from the systemic circulation, it gets diffused into the canaliculi of the parietal cell where it is an acidic environment. In the acidic environment, it is getting converted into its active moiety, that is sulfonamide is the active moiety, and that will come and bind irreversibly with the proton pump, that is H plus K plus ATP. So the active form is sulfonamide and it is an irreversible inhibitor. One more peculiarity is once it gets converted into its sulfonamide group, it cannot go back because it is ionized. So that is what is known as ion trapping. That will also help in increasing the efficacy of the drug. That is called as drug trapping or ion trapping. So even though if you see the next slide, when we see the pharmacokinetics, most of these drugs have a t-half of around 1 to 2 hours. But still we give them as once daily dose because even though their t-half is short, this is another example of hit and run drugs. Its action lasts for around 24 hours because it irreversibly inhibits H plus K plus ATPase. Only when the new proton pumps are synthesized, its activity returns. So as its suppression is for 24 hours, it's an example of hit and run drug. It inhibits both basal, that is nocturnal, as well as stimulated gastric acid secretion. There is no effect on pepsin or intrinsic factor secretion. Usually after stopping, the full activity returns in 3 to 5 days. So you give it as a entry coated tablet. The reason I told, because it is destroyed by gastric acid. So to protect it from gastric acid, you give it as an entry coated tablet. Another important thing, whenever you are prescribing PPIs, you should always write take it before food, half an hour before food, because food interferes with its absorption. And omeprazole is a CYP450 enzyme inhibitor. So there can be drug interactions because of this. The important drug interaction of omeprazole, one is with clopidogrel. What is clopidogrel? It is an antiplatelet agent. So it is again a prodrug. So for activation of clopidogrel, it requires this enzyme CYP2C19, which is inhibited by omeprazole. So omeprazole can decrease the therapeutic efficacy of clopidogrel. So that is one important drug interaction. Now, the most potent among these agents is lansoprazole. It is also safest in pregnancy. The fastest acting among these is rabeprazole, and it has minimum inhibitory effect on CYP enzyme. So least drug interaction is with rabeprazole. And esomeprazole, lansoprazole, pantoprazole, rabeprazole all can be given intravenously also. Okay. So now we come to drug interactions. So some drugs require acidic medium for its absorption. For example, ketoconazole is more soluble in acidic medium or lower pH. So when you are giving a drug that decreases gastric acid the absorption of these drugs gets affected. For example, uh, uh, this proton pump inhibitors decreases the absorption of drugs like ketoconazole. Then, as I said earlier, these are substrates as well as they can inhibit these enzymes, so can cause drug interactions. Especially omeprazole inhibits the metabolism of drugs like phenytoin, diazepam, and can result in its toxicity, can interfere with activation of clopidogrel, and can result in decreased efficacy of clopidogrel. Now, what are the adverse effects? These are relatively well tolerated drugs. There can be occasional diarrhea, abdominal pain. Atrophic gastritis can be there if you are taking it for a long duration, that can predispose to adenocarcinoma. Long term, it can result in vitamin B12 deficiency because of reduced absorption of B12. Similarly, because of reduced absorption of calcium, there is increased risk of hip fractures. In patients with osteoporosis, there is increased risk of enteric bacterial infections like Clostridium difficile infections, as well as increased risk for pneumonia. And sometimes, because of decreased acidity, there can be compensatory hypergastrinemia that can result in carcinoid tumor. These are very rare occurrences or rare adverse effects of proton pump inhibitors. What are the uses of PPIs? We use it for peptic ulcer. It's a drug of choice because the final step in acid secretion is inhibited. So we use it for gastric duodenal ulcers, for H. pylori eradication, NSAID-induced ulcers for prevention of rebleeding. We give PPIs. We also use it for stress ulcers, for gastroesophageal reflux disease. It's a drug of choice. For Zolliger-Ellison syndrome, non-ulcer dyspepsia, and for prophylaxis of aspiration pneumonia, that is as a pre-anesthetic medication also we give proton pump inhibitors. Now we come to the next major group, that is H2 receptor blocker. You know, H2 receptor, histamine will come and act on the H2, that will stimulate the acid secretion. So you have cimetidine, ranitidine, famotidine, roxatidine, nixatidine, loxatidine, all are inhibitors of H2 receptors. So these are all reversible competitive inhibitors of H2 receptors. The exception is loxatidine, which is a non-competitive inhibitor of H2 receptor. Competitive means it will compete with histamine for binding to this receptor. It has structural similarity to that of histamine. It is highly selective on H2 receptors, does not have action on H1 or H3 receptors, mainly help in suppressing the nocturnal or the basal acid secretion, which is dependent on histamine. It has got good oral absorption. Ranitidine is very commonly given. Very small amount is metabolized in liver. Cimetidine, we don't much use cimetidine these days because it inhibits, it's a microsomal enzyme inhibitor that can have many drug interactions. It also inhibits the synthesis of testosterone that also can cause many adverse effects. So we don't prefer using cimetidine these days. Since it is excreted mainly in urine, we need to reduce the dose in renal insufficiency, and cimetidine can have many drug interactions. So you can see here compared to the potency, the most potent one is famotidine, the least potent is cimetidine. And cimetidine also has high potential for inhibiting the cytochrome P450 enzyme, high chance for drug interaction, which is less for the newer agents. And regarding nisanidine, it has got additional anticholinesterase activity that can cause bradycardia, enhanced gastric emptying, and it is one drug with maximum bioavailability. Oral bioavailability is highest for nisanidine. Adverse effects, again, well tolerated agent. It can sometimes cause bradycardia, hypotension on rapid IV because of blockade of cardiac H2 receptors. So this should be given as slow IV injections. And on IV, there can be CNS effects like confusion, hallucination, impotence, galactorrhea, and gynecomastia is seen with cimetidine because of its anti-androgenic action, as well as it inhibits the metabolism of estradiol, increases the prolactin. Because of all those reasons, there can be gynecomastia, impotence, and galactorrhea. Okay, so what are the advantage of newer H2 antagonist over cimetidine? It does not have, it is more potent, long duration, does not have anti-androgenic action, less CNS permeability, hence less CNS side effects, no microsomal enzyme inhibition, so less drug interactions. Okay. So where do we use these agents? Just like PPI, we use it for peptic ulcer, stress ulcer, gastroesophageal reflux disease, Zolliger-Ellison syndrome, and for prophylaxis of aspiration pneumonia. So that is about H2 blockers. So we have finished proton pump inhibitors, H2 blockers. The next class that inhibits the acid secretion is anticholinergic agents. So you have pyranzepine, tilanzepine. These days we don't use much anticholinergics for peptic ulcer because proton pump inhibitors are having more potent as well as higher efficacy compared with these agents. So these are basically acting on M1 receptors. They suppress both nocturnal as well as basal as well as stimulatory acid secretion, but they are having poor efficacy and so many adverse effects, so they are rarely used these days. N-prostil, N-prostil and rioprostil are prostaglandin analogs. Again, they help in reducing the acid secretion. So that is for today's class. So main highlight is how acid secretion is regulated. Then regarding proton pump inhibitors, H2 blockers and anticholinergic agents, we discuss the examples, how they act, what are the adverse effects, uses and important pharmacokinetic parameters. Okay, so the remaining we'll take it in the next class. Thank you for listening.